You're all very welcome. This is our last webinar for the first part of the year, and it's a real pleasure to be joined today by Professor Colm Dunne. I'll introduce Colm to you in a moment, and I'm just going to run through a couple of notices just while we wait for people to join in. You can follow us on social media, and you can watch back previous episodes of QPS Talk Time on our YouTube channel at National QPS, and you can also follow us on LinkedIn at HSE National QPS, and certainly encourage people to do that. And just want to let you know about some of our new Walk and Talk Improvement podcasts. So this has recently just been uploaded with Professor Deirdre O'Shea, and Deirdre is talking about work motivation, self-regulation and performance behaviours to enhance quality and patient safety. So that's been hosted by Juanita, and certainly would encourage people, if you're looking for something to keep you interested over the summer when you're doing your walking and talking, you can have a listen to that one. And then again, to remind people of a recent podcast that we've uploaded with Keith McCandless. Now, Keith McCandless is one of the founders of Liberating Structures and a world-renowned educator. And again, great conversation there with Keith McCandless in our long list now of Walk and Talk Improvement podcasts. So in today's webinar, we're going to hear about how healthcare research is influencing practice within our health and social care systems. And we're going to talk a little bit about medical education and how it's evolving to address current and emerging quality and patient safety priorities, both in Ireland and globally, and how we can work collectively and future-proof our system to meet changing population demographics and needs. So it's a real pleasure to welcome today's guest, Professor Colm Dunne. Colm, you're very welcome to QPS Talk Time. Colm is the head of the School of Medicine in the University of Limerick, and Colm is the Foundation Chair and Director of Research there too. He was appointed Honorary Professor at Queen's University in Belfast in 2024. He's a Fellow of the Royal College of Pathologists in London and a member of the Royal Irish Academy Life and Health Sciences Committee. Colm is a trustee and a council member of the Healthcare Infection Society London. Colm, welcome to QPS Talk Time. You might just tell us a little bit about how you've ended up in your current role and where you started and how you've come to be here in UL.
Thanks, John, for the question. It's a privilege to be here today. I'm very grateful for the invitation. I would have begun my third level education at University College Cork in Ireland. I'm a microbiologist by initial training, and then went on to take on probably leadership positions, having done a postdoc and spent some time at Michigan State in the US. I was general manager of a cancer research center for a period before joining multinational Glanbia PLC as their director of research, and joined the boards of a number of the companies under that banner before returning to the University of Limerick in, I think, early 2010, when the medical school had just been established here. I joined the executive as the foundation chair and director of research, and I've been lucky enough to be in a position where I could influence the hires and the recruitment of staff, faculty, clinical academics in the region, and build up our research strategy. And then more recently, about 3 years ago, took on the role of head of the School of Medicine, or Dean of Medicine, as you'd know it in other areas.
Great. And tell us just a little bit more about your research work beforehand, and how you ended up kind of getting into healthcare research.
Again, I was very lucky in Cork. Many years ago, I worked with Professor Fergus Shanahan, Professor Jerry O'Sullivan, and others. Before that, with Professor Fergal O'Gara, where all of the work that we were doing, microbiology oriented, was very applied. It was looking at solutions before we started to do kind of ivory tower, insulated and academic work that didn't have an application in real life. So that evolved from looking at crops and plants and antimicrobials. Many years ago, our new nemesis, Stenotrophomonas multifila, was known as Xanthomonas multifila. And before that, Pseudomonas multifida, and I worked with it as a vehicle for molecular manipulation. And now I'm meeting it in the context of hospital-acquired infections, where I found myself working with colleagues here in the region and internationally, looking at CPE, endemic infection risks, and looking at interventions and trying to understand how antimicrobial stewardship, how being prudent with our prescribing can have a real impact for patient outcome.
And that's a real example of taking something from the laboratory and like you said, putting it into the real world. And like, what did you learn about how healthcare is different from let's say what we learn in the lab?
Yeah, it is that fundamental distinction between academic research, where you're looking at trying to develop new concepts or gain new insights into some aspect of a trait or characteristic, a mechanism that is mediating an observable effect, which is all very interesting inherently. But if you try and apply that and actually put it into a real world practice, you very often find yourself coming up against the barriers of the end user, or they often say that the biggest problem with any plan is when you try to implement it, and that is exactly what happens in healthcare, because you may come up with a concept, something that you believe is going to be revolutionary, but when you go and speak to the patients, go speak to the practitioners, you find that either there's something already there that does that very, very well, or alternatively you find that there is some aspect of what you're trying to use and the way that you've designed it that doesn't work in real life. And it does bring into context that relatively new concept of public and patient involvement, that participatory health research aspect of engaging all the stakeholders in the piece of work you're going to do, including understanding the question before you start to invest any resources, so that when you do come up with the answer, whatever the answer is, and maybe it's the restaurant at the end of the universe, the answer is number 42, but at least when you get there, you know that it is what you've been looking for, and it can be useful to society at large by the time you've done that.
Yeah, and this is something important to us in quality improvement and safety, is this idea of co-production, that we can only make good answers or good solutions if we co-produce them. And that means sharing power with people, all the people. What have you learned in what you've worked on? And I think you've done some work in antibiotic prescribing and antimicrobial stewardship.
Yeah, I think this is my opportunity to be slightly controversial sometimes, and because this is a live webinar, you can't stop what I'm going to say, but and that's a joke. But the reality is that we have looked at some of those really difficult questions. We've looked at the challenges of, as you say, out of hours prescribing, and if we try and remember that family doctors, community doctors, general practitioners who are meeting patients who are they're experiencing a challenge. They're experiencing a challenge that means that they can't engage with a healthcare professional in that normal run-of-the-mill 9 to 5, Monday to Friday type situation. And they're sitting across from a healthcare professional who is listening to their problem and maybe understands, for example, that they have a respiratory infection. Maybe we're in one of those seasons where something is rife. They know it's viral, and yet they have a patient opposite them who is expecting to be prescribed something because they need to have that level of confidence that their medical practitioner is going to give them something that will make a difference. And that pressure to prescribe sometimes, and I think more historically, has led to the inappropriate prescribing of antibiotics, knowing full well that you may be looking at potentially preventing a secondary infection, but the primary cause for presentation is viral, and therefore that antimicrobial will have no effect. And where we are now, I think, is that on the basis of that work and other work, there is that understanding, that level of confidence that practitioners have to say, I could give you an antibiotic, but it's actually not going to do anything. And patients are increasingly aware of antimicrobial resistance. They're increasingly aware that there needs to be a careful prescribing, so that we do have that arsenal of product available to us to protect ourselves in the future. So that careful prescribing practice, I think, is now something that we can look to and know that when we do adopt that position, it will be understood.
And tackling complex problems like this, Colm, obviously it's not just a microbiology problem. It's a society problem. It's a psychology problem. It's a business problem. And how do we weave all those strands of academia together, to come up with these better solutions?
Again, a great question, John. I think there are multiple facets to that, and I'm going to begin with the one of trying to understand the problem. Within universities, our mission is to be an educator and a researcher. When you are working within a healthcare system, be it the HSE in Ireland or the NHS in the UK or the VA in the US, your primary focus is yes on quality improvement, yes on innovation, but fundamentally it's around patient outcome and delivery of care. I suppose we were also looking at disease prevention and lifestyle change as well, but generally at the core of day-to-day healthcare practitioner activity is that patient engagement and care for them. That means that when we look at problems that may be occurring in a healthcare facility, in a healthcare setting, the academic freedom that somebody within a third level institution, a university, a medical school has, allows them to delve quite deeply into the problem and sometimes come up with those insights that would be quite problematic within a healthcare system to A, acknowledge, and B, start to deal with. So we do have that ability to work together in that. The second thing, you're absolutely right, is around then trying to implement either an intervention or a solution. That could be something purely in the clinical setting, which if we look at antimicrobial resistance, when we look at polypharmacy, when we look at inappropriate prescribing, we're not only dealing with the biomedical scientists working in the lab, we're not only dealing with the pharmacists who are dealing with the antimicrobial stewardship and the clinical practitioners who are prescribing, but we are also then looking at environmental monitoring. We're looking at the effects of those antimicrobials on species that may develop resistance. And we are also looking at it in a One Health context, where we prescribing and using antimicrobials for human health can't forget that they are also, to a great extent, used in animal husbandry, in veterinary health, and so on. And a lot of the work that we have started to do has looked at not only the incidence of resistance, the evolution of new species with antimicrobial traits, antimicrobial resistance traits, excuse me, but also monitoring our drinking water and monitoring what's happening across that One Health spectrum of activity. And we are seeing improvements in Ireland, and that's actually a great thing to see.
So these are complex problems, aren't they? And they need kind of a lot of thought, I think, in terms of understanding, like you said, the problem before we jump into solutions. Did I hear you as part of your research you discovered a new strain of bacteria in one of your studies?
We have. So I would again begin, John, by being a little bit historical in perspective. The team that I work with, clinical microbiologists in University Hospital Limerick, surveillance scientists there, we've been working together for almost 15 years. And over the last 10 years, we've established ourselves as one of those locations in Europe which is acknowledged as facing difficulties with regards to outbreaks of antimicrobial species, but also as being to the fore of interventions, education around training that will mitigate those risks. And most recently, with a very significant amount of support of the HSE Buildings and Estates team and the management of the hospital, we were able to remove 20, I suppose, white good, drains, shower units, sinks, and toilets from a ward in which there was an endemic outbreak of CPE. Working with colleagues in Queen's University Belfast, where I have an honorary position there, we were able to take all of the material that was adhering to those drains. We were, to use a technical term, we boiled it down. We sequenced everything that was in there. We used very high power bioinformatics. So my colleagues, Professor Brendan Gilmore in Queen's, Professor Stephen Kelly in Queen's, and colleagues, Professor Nuala O'Connell and Dr. James Powell here in Limerick, we put together a full metagenome profile of all of the species that were present in that material, the biofilm, that dark sticky material that adheres to the drains. We were able to look at and identify and characterize all of the species that were in there, all of the antimicrobial resistance genes that were in there, and then to correlate that with some of the outbreaks that were happening on the wards. Now, if you were to take one particular perspective, and it could have been adopted by the hospital management, which is, please don't look at this, because if you look, you will find a problem. Whereas instead, they were forward looking, they were supportive. They knew that if we looked and identified what the problematic species were, that we could then start to do something to mitigate that. And as part of that, we identified a new species that has not been reported anywhere else. So this is a Pseudo-Citrobacter limericensis, or to translate that, Pseudo-Citrobacter from Limerick. I wasn't going to name it after myself because we don't know what the problems are going to be in the future. So it's better to name it after the city. But it is, I have to say, a unique piece of work internationally. It very much underpins that understanding that wastewater systems are the reservoirs that are most problematic within hospitals. And it's a testament, I think, to the forward-looking and collaborative nature of the HSE's buildings and estates, all of the clinical academic staff, and the management there. They could have said no, but they didn't.
And Colm, I'm struck again listening to you, just how you're weaving all these strands of different people's abilities and skills, to solve problems. And what does good teamwork and collaboration look like in modern healthcare? And how do we bring these things together like you've done in so many projects?
It's a recognition that we all bring something to the table, I think, isn't it, John? It's understanding that universities are multifaceted. We have business faculty who understand the commercial realities of selling antimicrobials or selling medical devices or modeling healthcare expenditure versus return, and health promotion and illness prevention. It's about looking at lean and Six Sigma to understand how healthcare delivery can be optimized. It's about HR practice. And then it's also about biomedical engineering, microbiology, biochemistry, new product development, new medical devices. But none of that can happen in a meaningful way unless we have collaboration with our healthcare colleagues and patients, those who are going to be affected by that, and those in the community who may be looking to improve their lifestyle and increase their chances of avoiding illness. So when we look at all that as a holistic piece, a spectrum of activity across society, surely we have to work together to achieve what we're trying to achieve. Otherwise, we are silos. We are investing probably quite a lot of money or assets into problems that we think are real, or in other words, developing solutions for problems that may not exist.
Yeah, so I think our audience at this stage will get a pretty good understanding of why you are now the head of the School of Medicine in the University of Limerick, because obviously these are all the values and the critical competencies that you want to bring for young and emerging new doctors in training, and how are you taking these ideas into the medical school?
Thanks, John. I'll take the compliment. We don't get them often enough. I think you're usually given out to at some point. The medical school in UL was established as being something quite different. Pat Fottrell, who was a former president of the University of Galway, or maybe NUIG, was asked by the government to look at medical education back in the early 2000s. There was a process that the government led for the development of a medical school, and the University of Limerick put forward a graduate entry program. So what that meant was that for the first time, every student who was coming into that medical school would have to have had prior third level experience. So they were bringing maybe life experience if they were a little bit older, but they were also bringing a prior degree, whether it was engineering or arts, or famously, fashion design. But it meant that when they came into the program, they wanted to be there. It wasn't the situation where many of us would have experience of somebody going into medical school, not because they themselves inherently wanted to, but maybe because their parents wanted them to. These students that we were bringing into the school had made a very conscious decision and an investment in time and in money that they were going to elongate their time in third level education because they absolutely wanted to be doctors. The program, which we've now been established 18 years this year. We'll obviously have celebrations in 2 years' time. We've graduated more than 1,800 doctors who are practicing as consultants, as attending internationally. Many of those are now the ambassadors for the school, but they're also in senior leadership positions in their clinical roles and in their careers. And we've now gotten to a point where we've decided, with the help of the university and in response to the government, to establish a school entry or direct entry program. And that will happen from September 26. And that changes the shape of medical education in the Midwest of Ireland and nationally. And we're also going to do a number of things around capital investment. So we have, at the moment, we have a medical school on the campus of the University of Limerick. We have colleagues across about 200 general practices that are affiliated with us. We have a clinical education research centre in Duradoyle in the University of Limerick campus, which we are going to extend in the coming year or two. We have just put a new clinical education research centre into the maternity hospital in Limerick, and we are making a very large decision now. And that decision is whether we want to extend where we are on the University of Limerick campus, essentially tripling the capacity we have for medical education, or whether we are going to decamp with the support of the city centre, with the city council, and the government, to move and develop a standalone landmark medical school campus in the university, in the city, establishing a city campus and a presence for the university there. All of that reflects the fact that the school has developed programs with the involvement of stakeholders. We have our clinical academic faculty who are co-employed, if you like. So they are probably 50% clinical practice, working with the HSE, working in general practice, and 50% in the university, straddling both the academic sphere and the clinical sphere. And they are also allowing us to ensure that the education program that we are offering stays current. It is innovative in one way, and it's actually based on a tradition in another. The tradition is Ireland's tradition of producing high quality, highly competent, very well respected and very welcomed doctors internationally. But it is novel in that it is based on problem-based learning. It is based on self-directed learning. It's based on the students working as small interdisciplinary teams, working together to understand what they don't know, then going to find that information and sharing it with their peers. And that prepares them very, very well for moving into the intern year and into practice. That was a very long-winded answer. I apologize, but hopefully it's comprehensive.
Yeah, and I think it gives us a great insight into what you've been doing in UL and what UL itself has been doing, and I suppose medical education is restricted by regulations and standards, but at the same time, like you said, you have this maybe space to be innovative in being a new medical school in Ireland. And what do you think are the skills and competencies that doctors who are graduating in 2025 need for the next 50 years of or whatever it is length of time they're going to practice? It's a very different environment than it was when I graduated maybe 25, 30 years ago.
Yeah, no, again, a great question, John. I think that I could answer that very simply by saying that we're in an era where we're going to be technology driven and technology aided. I think we have to look at generative AI. We do know that there are now, through the HSE, units that have been established across the country, I think predominantly in Dublin, looking at the use of AI in diagnostics. That's very important. But we also have to not only acknowledge the fact that AI exists, but also acknowledge the fact that our students are going to use it. And we, as practitioners in whatever realm that we work, are going to use this. The information that we get from AI still has to be interpreted. We do have to have the underlying understanding of what the material is, what questions to ask. And when we interpret the answers we get, are they relevant? Are they correct? Is there something completely, incorrect in there and implausible in there? The program I mentioned problem-based learning. The University of Limerick School of Medicine, which has touted itself as being somebody at the forefront of using problem-based learning, is really building on a foundation that was established in McMaster in Canada in around 1959 or so. That program was adopted by Harvard, and they got rid of the problem-based learning nomenclature, and they called it the new pathway, and it became famous as the new pathway from Harvard, but in fact was established in Canada. It isn't novel now. It is very well established now, and the ways of working with it is very well understood now. But it's how you modify that so that you are not only asking the students to become competent, not only to be knowledgeable and aware of the subject matter that they're dealing with themselves, but it's allied with competency. And that competency oriented education and the assessment that is competency based means that we will continue to have students who are graduating from the University of Limerick, Cork, the Dublin schools, and Galway that are welcomed internationally, and that when they go into practice as early career doctors, that they are bringing that level of confidence around the skills that they've acquired, such that they're not a burden on the teams they're joining, but instead are making a contribution as quickly as possible.
Yeah, yeah. I mean, one of the other things I suppose that has changed in healthcare since I qualified is, again, the importance of the role of patients and the public, and we talked about that a little bit earlier in terms of research and how we integrate that. Do you bring that into the education of your doctors in UL?
We do, John, in a very big way. The first thing I would say, and I have to acknowledge the Public and Patient Involvement, or PPI Ignite program in the country. I mean, it's led very much by Professor Dineen and others. They have provided the infrastructure for a program that enables that type of involvement and learning around that. I think that is something that is hugely credit. There's a lot of credit. It lends, I think, a credibility to the programs that we have within universities and those in clinical practice when we put a framework around that exercise, exactly as you described a minute ago, John. But the other thing is that some of the universities and some of the medical schools, and particularly the University of Limerick, have actually made faculty appointments focused specifically on that. I have two within my school. So I have Professor John Salzberg, who joined us from McGill in the US, and Professor Anne McFarland, who joined us from previously working in Galway. They lead our participatory health research unit. They are faculty focused primarily on understanding patient-oriented, patient-led, and patient-derived challenges, whether they're from particular patient groupings or whether they are from vulnerable populations, such as immigrant populations, who have very different cultural norms. And a lot of the challenges, for example, we look at the emergence of sickle cell now as a problem in Ireland, where we wouldn't have had that traditionally as being a major issue. These kind of challenges need to be understood so that we can put the frameworks around them, the infrastructure around them, the care pathways around them that mean that our health system can deal with those.
So they're involved in I suppose helping, coaching, teaching your students to regard these things. You also, though, you get your students out into, again, real world settings where they do encounter patients where they are, as in, understanding the challenges, the work of being a patient.
Yeah, John, one of the things that is a characteristic of our program is that almost from the time that our students arrive into the University of Limerick, they are given insight into the experience of somebody who will use a healthcare system. Our early patient contact program means that they are partnered with somebody who may have a chronic health condition. They may be a pregnant woman who maybe they have to take 2 buses or a taxi in order to go and wait in the waiting room before they meet the general practitioner or a hospital consultant team. And our student is with them, and they experience the waiting times, the difficulties around travel, the difficulties with our transport infrastructure, and also understand the emotional impact maybe of having bad news, maybe the financial challenges of having to travel and engage with healthcare. It means that from the very beginning of their education with us, they are not simply looking at it as a potential healthcare professional in an isolated, cosseted fashion. Instead, they are understanding the end user and the challenges that they face, and hopefully become empathetic to the situation they find themselves in.
Yeah, yeah. I'm struck by, I heard Arthur Kleinman speak a number of years ago, who's kind of one of the founders of medical anthropology, and talked about a program at the University of Leiden in the Netherlands, where they would send students out very early in their experience to spend a few days with families who are caring for people with significant care needs, cleaning, moving, feeding, and how when the students would meet up years afterwards, it was one of the first things they would talk about in terms of, where were you for your care experience, because it was something that really defined them as a group. And I think these are I think important things for I think a university experience to give to people, is that one of the things that we're trying to teach people is that the importance of that kind of service, and being able to care, and forming your identity as a healthcare professional.
And also remembering we're all human. That like the human experience, that journey that all of us are on, is important to remember. To remain empathetic, to remain sensitive to people's challenges. Yeah, and as I say, remain human. I think that's the term.
Yeah, we had at the healthcare system ergonomics and patient safety meeting last week in Trinity, and again, one of the things that really emerged strongly in that was the importance of humanity in human factors. That everybody is human in the system, and again, I think one of the things, taking a human factors view, is that it's about ensuring the well-being of all the people in the system. That you can't expect that the well-being of patients to happen if you don't have the well-being of staff. And equally, if we don't respect the humanity of patients and families and those we care for, then it's very hard to remain human ourselves as healthcare professionals.
And it is a bit of a soundbite, and maybe it's a little bit glib, but we do within our school emphasize a work-life balance. And I come back to one of the very earlier points I made, that we're looking to graduate doctors and paramedics and biomedical scientists and public health specialists who are going to have a long, healthy, productive career. When our students arrive and we talk to them and they say they're a long distance runner, we say keep running. If you're a musician, keep playing and practicing. If you're an artist, keep producing, because we all have a tendency to become fully ingrained in what we're doing. We become obsessed or absorbed to the point that it impacts our life, and that does not lead to a productive career.
Yeah,
So
one of
we
the
do
great
emphasize
risks.
those.
One of the great risks, I think, for healthcare professionals, and especially doctors, I think nowadays, is burnout. And do you think
Yeah.
there's things we can, skills and ways of thinking that we can imbue in our students that help them not, to be at such a risk of burnout?
I think there are two aspects to that, John. One is trying to, as you say, instill a particular skill set into students if they don't inherently have that. But we also have to look at our healthcare systems, what we expect of the employees of the healthcare system, the hours that people are expected to work, the conditions in which they work, and that interaction, as I keep saying, with people that may be very stressed. That leads to an emotional involvement. There is that, the cortisol spikes and everything that goes with that. That is, and all of the other stressors. We need to be very cognizant of all of that. We probably don't provide enough counselling for those who are in in situations where they're meeting those situations. We certainly don't, I believe, provide enough of that for those who are first responders, those who need to be given downtime to I guess digest what has happened to them, to deal with the trauma that they may have experienced before they have to go out on the road again
Yeah.
to immediately care for somebody else in yet another, highly
Yeah.
pressured situation. I think that there is that type of, there is a recognition of it. I also think there is a recognition that resources don't allow for things to be optimal, but we do need to work towards improving the situation.
Yeah. Yeah. How is UL thinking about the future, Colm, in terms of what Ireland needs in terms of and I'm talking here not only about the type of doctor, but just numbers of doctors and where they're going to be. Is that something that you're thinking about?
Very much so. We have, as I said, a graduate entry program at the moment. We take in every year 198 new potential doctors. That is our target every year, and we are limited by capacity. We are limited by the size of the buildings that we have. We're limited by the amount of space for our tutors to work, and we're limited by clinical placements. So the latter end of the program, years 3 and 4, is where our students are out there engaging with patients in a parallel consulting way in general practice or in the hospital settings. They all need to be opened up so that we do have the opportunity to bring on more students. We are also looking at the new school entry or direct entry program, where we're going to begin with 30 students in September 26, and that will increase in numbers. And overall, our school has the ambition to double in size over the next number of years. That will make a significant contribution to workforce planning, bearing in mind, and this is very important, that the way that our intern year is now managed is going to change. There is a new intern governance model being established. It is being driven by the NDTP, or that unit within the healthcare system that looks at training and early career doctors. We are going to see the Irish Medical Schools Council, the group of the deans of medical school that I sit on, where we have supported and have responded to a request to design what that is going to look like. In particular, I have to acknowledge Professor Paula O'Leary in UCC, University College Cork, who has driven that. We are going to see, I think, an increase in the number of intern places available every year. We are going to see an improvement in the requirements, the learning outcomes, the skill sets that those interns are going to have to acquire in that first year of practice to enable them to not only be competent, but also to compete for higher training. And we're going to see a move towards a shared or maybe more homogenous set of learning outcomes for those graduates who are leaving medical school in Ireland and then entering into the clinical practice. The University of Limerick is at the core of all of that. We are part of this grouping of medical education institutions in the country that all want to maintain the standards that we've all become known for, and also to enhance that. So we recognize the challenges, some of which we've talked about, but also see how we can be innovative, how we can continue to produce the next generation of medical and clinical leaders.
And what about patient safety in that? Is that something that's important, to universities, do you think? And as we educate our doctors, and again, as we see them go through their intern years and start to work in again the real world where the university has less of an influence.
I think it does begin with, actually, I'll answer this slightly different to the way that I was going to, actually, which is that I think it's important for any new cohort of healthcare students, be they nursing, allied health, occupational health, speech and therapy, whatever that may be, that they understand that when they come into university, they are in the early stages of a healthcare profession. It is patient-centered. It's around ensuring that they understand that the knowledge that they're acquiring isn't simply the fundamental concepts of basic science, but it's instead how that can be applied and made useful for in lifestyle in terms of illness prevention or health promotion, and then subsequently into treatment and innovation, be it new products, new drugs, new medical devices. But they need to understand from the very beginning that that is the journey that they're on. So that is the first aspect of it, so that they do absorb the knowledge, knowing that they're going to apply it. In our medical program, for example, when our students move into year 3 and 4, so this is where they're in clinical placement, they are not only supervised by practitioners, they are also assessed by practitioners. We use a thing called an ITA, an in-training assessment model, where there is constant dialogue. There may be parallel consulting, where a patient is met by a young student doctor, and then subsequently met with them and a general practitioner, to the point where there is that learning and that experience of ensuring that what that student did was correct, what that student asked was correct, that the tone that was used in the recording of data was correct. And then we also have a prescribing safety module, where we're ensuring that, and this is being very superficial about it, but that the mathematics of looking at a drug entity and saying that the dosage is calculated by X mil of product by X kilogram of body weight in that particular gender setting is what is appropriate. That kind of assessment comes into play, all of which emphasizes safety and care and appropriate levels of detail. We also talk about disclosure and the fact that what you do and what you say and the tests that you apply and so on are going to be and should be communicated along with any bad news that may come in that context. And then into the intern year. So as you know, the intern years are the responsibility of the universities, of the medical schools. So we have tutors, we have intern network coordinators. In the University of Limerick, we've just established a clinical academic position, a secondment from the HSE, where we're going to have a senior clinician who's going to have overall responsibility for the intern year. So in other words, the first year of HSE employment, but in return for doing that, they get a clinical professor position with us in the university. That emphasizes the importance of that year to us, but it very much underlines the fact that that year is where you take what was learned in university and you apply it in clinical practice with safety at the very core of it. Again, a long answer, but it says that it begins at the beginning and goes through.
Yeah, and I think it's great to hear that, and I think that those are really important things. That there are critical times, I think, in the formation of a doctor. I think that intern year is certainly one of them. We have some questions from our panel, from our audience, which I might just share kind of for your thoughts, Colm, if that's okay.
Of course.
Rajshri there is asking, how can we ensure that clinical innovations are evidence-based and effective? So again, that's a big question, but and again, I think it's maybe drawing from that broad pool of academia that a university kind of has access to.
Yeah, I think there are a number of elements to that. I think the first element is actually time. I think those who are working within the HSE, the Irish system, aren't always enabled to have time dedicated for research. So that time to reflect on what they may be doing in practice and identifying a glitch, an issue, a potential improvement that they can work towards. And because of that, they don't always have the opportunity to do anything other than look at something and say, well, I think this would be really good. The gathering of evidence, the design of the study, the appropriate use of statistics, certainly within our university is enabled within the university, within the medical school, where we have core staff who are available to our clinical colleagues, but also through the establishment of a new research directorate within the region here. So it's headed up by Professor Declan Lyons and colleagues. It is the first in the country that I'm aware of where there is a team focused entirely on supporting research in clinical practice. And that is an instrument that is going to make a difference because it will provide the supports. And to answer that question, It is around then bringing together teams of people who have different skill sets, different perspectives, and who are able to holistically work together to come up with an answer that is relevant.
Great, yeah. So kind of the importance of structures that support that partnership then that's needed. And another question here from Helen Gibbons: how can we facilitate partnership here? Just what we're talking about between busy clinicians and academia to enhance research opportunities and evidence-based practice. I think that's maybe what we were just talking about there. And you know, and again, you know, obviously there's been the Spark program has really, I think, literally ignited kind of a great interest in this across kind of clinicians, and is it reaching into academia as well?
It is, John. I think the other thing is around opportunities. There are two things. There are postgraduate opportunities, postgraduate research opportunities. Master's programs are shorter than PhDs. We have the MD degree, which is a 2-year research degree, typically in Ireland, which is that middle ground between a bachelor's degree and a PhD. Many people use it as an opportunity to do a project to get some papers published that may make them more competitive for specialist training schemes and so on. They are probably underutilized. The HSE, I think, is very supportive of people who want to take time. And we certainly, and certainly within my research network, I've been able to benefit hugely from clinicians who have made use of those supports. That is one thing. The second thing is, when you look at our medical school, we look at other medical schools, we look at other departments across the universities, and Limerick in particular are developing what are called micro credentials. These are much smaller units of learning opportunity. They can be stackable. So in other words, you can do one this year, one next year, another one or two the year after. And when you combine those, it's enough for another qualification, be it a diploma or later on a degree. But they provide the skill sets. They provide the experience to build up knowledge around appropriate approaches, methodologies, maybe mathematical models, maybe looking at, I come back to maybe something like Six Sigma or Lean, that can be applied, but you do it in a chunkable and very, you know, accessible way rather than taking on a very long program of work.
So Colm, maybe just to end, I'm going to ask you to do a little bit of future gazing, and you know, you've had the opportunity to work outside of Ireland. I think you spent some time in the US. You certainly collaborate with lots of people from around the world. Where would you like to see Ireland and you know, and UL and our other medical school, and also not to forget all the other professions who are trained by our academic institutions? You know, where would you like to see us in 10 or 15 years time, you know, and what's going to be important to get there?
It's a big question. Third level education and healthcare are probably the single biggest investment that the government makes in knowledge in the country, not only in terms of revenue that comes into our tax base that is then invested, but also in terms of people. It's important that we work together. It's important that we understand. I come back to the missions. The mission of the healthcare system is to prevent illness and care for those who encounter it. In the universities, it's around education and research and innovation. And in some way, they surely align, they overlap. I've been very lucky to look at international healthcare systems. I've worked with colleagues, in particular, Professor Tom O'Toole, who is in Brown University in Rhode Island. He's also an Undersecretary for Health in the VA system in the US. And he and I and colleagues within the HSE have looked at, for example, absenteeism in the HSE, understanding across all of the hospital groups, across all genders, across all age groups, across all specialties, where absenteeism happens, the cost of it, whether it's an opportunity cost, financial cost, people cost, and then to try and recommend interventions that are going to make a difference in that. That is a tremendously important piece of work, and again, unique internationally. What's important in this is that what we've seen in Ireland is exactly mirrored in what's seen in the VA system in the US. So we are not unique. What we are unique in is that we are small. We're a small country where all of our hospitals and a healthcare system by definition forms a cluster. It should be possible to make improvements. It should be possible to do it in a way that is reasonably generalizable. We have nothing that is very, now you can't say very unique, but there's nothing unique in Ireland that can't be transferable into international areas, and we can become a leader in that. And I think third level education institutions, medical schools in particular, combined with the healthcare systems and the academic health model. The academic health sciences model is something that Colm Henry and others within the HSE are looking at very carefully. It is a huge decision point in Ireland. It is the decision point around the appointment and the shape of, and maybe the future of, those chief academic officers. What role are they going to play in interfacing between the universities and the healthcare system? I would argue that the schools of medicine, the schools of nursing and midwifery, the schools of allied health, and the hospitals might be a level where we will achieve things very quickly. But that model, that way of working, needs emphasis, it needs investment, it needs attention. And I think that's where we will start to make a difference. And in 10, 15 years' time, we will see the benefit of that.
Yeah, that's super. Thank you so much. And I think those of us working in quality and patient safety would see that too, that the skills and the partnerships we need are broad. They're not just immediately within healthcare. I think we need to work with our colleagues across academia. Again, not just healthcare academia, but psychology, human factors, engineering, IT, computer science. Healthcare is just so complex now that we need to bring in lots and lots of different partners. And I think the sooner we do that, and I think anything that facilitates that, I think is going to help us. Well, Colm, thank you so much. I've really enjoyed our chat. What a great way to finish our season. Thank you, and I wish you all the best in UL and like I said, all of our universities around the country. And what an amazing job you do educating all of the professionals who go on. And I've had the pleasure of working with many of your graduates from UL, and they really are great advocates and ambassadors for your programs. So keep up the good work, and thank you very much.
Thanks very much, John, and to Juanita and Chris. Thank you.
Great. Well, that's the end of our session for today, and like I said, it's the end of the season for our first half of the year. Thank you, everybody, for joining us. Thank you, Juanita and Chris, for being in the background and doing all the hard work and bringing the session together. Like I said, when you close out from today's session, you will get a form just to give us your feedback, but please do include some of your ideas as to things you'd like to see us talk about next year, or sorry, in the next season later on in the year. And if you want to contact us in the meantime, if you don't have any bright ideas today, you can come back to us with some ideas. And we're open to any ideas that you might have and to finding people. And I think from today's conversation, we can see how broad the partnership we need to have is to make healthcare better. So thanks, everyone, and we'll see you in September.